What I'm going to talk to you guys about today is advanced OCT imaging guided intracoronary calcium management. So this is past the basics of just seeing and identifying calcium, yes, no. It's a little bit more detailed for those of you who want to integrate this into your practice. Well, the first thing to understand is, why do we even care about this? Well, the reason is because OCT definitely, severe calcification definitely impacts device crossing. It can cause delamination of the stents and the polymers, which actually likely has a significant impact on the ability to stop neointimal hyperplasia. And obviously, this is the elephant in the room, and that's that significant calcification, whether recognized or not, can lead to significant underexpansion in the stent, which hampers long-term clinical outcomes. So when we look at the risk factors for target vessel failure, we'll notice that amongst these, which were included in Illumian 4, moderate to severe calcification has a significant hazard of 1.6. And what's very interesting about calcified arteries is that if you do not treat calcified arteries, they tend to have a relatively more stable progress compared to severe calcification when you intervene on them, because the likelihood of plaque rupture in a severely calcified artery is lower, and thus the ACS is lower. So these are largely the ischemia style stable CAD patients. And as a result, if we're going to treat them to prevent a worsening outcome compared to medical therapy, they really need to be treated properly. So there's nothing better than going through the fundamentals at the beginning of a lecture. So let's start with the fundamentals. The first thing are some of the definitions that you should understand that we see on a day-to-day basis. So that includes moderate calcification is by angiography defined as that seen only during cardiac motion on one side of the vessel. On the contrary, when you can see without cardiac motion on both sides of the vessel, this tram tracking appearance, this is the angiographic diagnostic criteria for severe calcification. Now, this is a very elegant study. So in 440 patients, all patients underwent angiography, OCT, and IVUS. So let's see what we learned in these 440 patients. Well, we learned that IVUS was able to pick up calcium in 440 vessels, 82.7% of the time. When we looked at OCT, we could pick up some calcium in 77% of the time. But out of all the patients on angiography, we only saw calcium 40% of the time. So what that means is that the sensitivity of OCT and IVUS to pick up calcium is superior to angiography, but the specificity on angiography is actually very, very high. And the reason that's important is because from this paper, if you look, only those patients who had severe angiographic calcification had an impact on minimal stent area and expansion. So fundamentally, angiographically invisible calcification does not impact stent expansion. Severe angiographic calcification does impact stent expansion. Where moderate to severe fits in remains to be determined. Most of us are familiar with the appearance of calcification on IVUS. The typical criteria, many of which Gary pioneered, are moderate calcification above 180 to 270 degrees, and severe in greater than 270. And as I mentioned previously, angiography has a poor sensitivity compared to IVUS, but a very high specificity. And we typically start to see angiographic calcification when we have an IVUS arc of calcium of 110 degrees. Thus, fundamentally, compared to IVUS, angiography has a poor sensitivity but high specificity for detection of calcium. Now, OCT makes it much easier to be able to identify calcification because OCT is a light, and light can penetrate through a crystal, and calcium is a crystal. And the criteria for determining whether calcification is severe or moderate is the same as that with IVUS, but you have more utility in the OCT criteria to be able to identify angiographic calcification. So when OCT calcification is 101 degrees in arc, 4 millimeters in length, and 0.57 millimeters in thickness, we start to be able to detect it on angio. You'll notice these numbers are going to become very relevant shortly as we talk about scoring systems for plaque modification and calcification. So compared to OCT, angiography has poor sensitivity, but high specificity for detection of calcification. This is an important slide because it shows in the same patient the appearance of calcification by IVUS and OCT. And clearly the advantage of the OCT is to be able to determine the thickness of this calcium, which we recognize is a major predictor of stent expansion. Many of you are familiar with our rule of fives, the influence of calcium on stent expansion. That is that when you have a calcium that's 0.5 millimeters in thickness, 5 millimeters long, and 50% of the vessel arc, these patients may end up with stent underexpansion. The more of these criteria you have, the harder it is to expand the stent. We consider advanced lesion preparation when patients have a calcium score of greater than 3. So in the presence of moderate to severe angiographic calcification, OCT can aid in determining lesion preparation strategy. Of course, light can penetrate through calcium, thus in addition to arc and length, thickness is also a major determinant of stent expansion by OCT. So let's next talk about treatment. So there's two goals of treatment for calcium. One is to allow you to actually cross the lesion, and that enables lesion access for upscaling balloons and stents. The second is plaque modification, debulking calcific plaque, inducing calcium fracture, and maximizing the luminal gain. Balloon-based strategies include non-compliant, specialty balloons, and ultra-high pressure balloons, of which, in my personal opinion, the ultra-high pressure balloon is the only balloon of any significant value. There's, I believe, very limited data to show the utility of these devices in facilitating calcium fracture. But of course, and as a result of that, the guidelines support these really to present slippage in in-stent restenosis or osteal lesions with the 2BC evidence. Non-balloon-based strategies include laser atherectomy, rotational atherectomy, orbital atherectomy, and intravascular lithotripsy. I should remove that because when I made this slide deck, it was not FDA approved. Of course, Shockwave was FDA approved on Wednesday in the United States. Okay, so how do we use this clinically? Well, we have to be not so simplistic as to just treat all angiographically severe calcification the same. And that's where we use OCT or IVUS to assess calcification. And if we have an uncrossable lesion, clearly we can't image. And as a result, crossing facilitating devices are largely orbital atherectomy or rotational atherectomy. If you can't get your OCT catheter, it is unlikely you'll be able to pass a laser or intravascular lithotripsy or even a specialty balloon. In which case, when you are able to cross the lesion and you perform OCT or IVUS, 3 patterns of calcification will be present. Deep calcification or medial calcification, and you'll see I will rename this term because, as Gary will tell you, deep calcification cannot be seen on intravascular imaging. It is simply deep within your cross-section or superficial within your cross-section. And nodular calcium, which is gaining much more attention, quite rightly, because the clinical impact of these in nodules is very poor. So when we have deep calcification, we use a different strategy, superficial a different strategy, and nodular a different strategy. Let's go through this together. So all calcium visualized by contemporary intravascular imaging devices is superficial. Superficial calcium on OCT can be categorized as thin cap fibrocalcific and thick cap fibrocalcific, i.e., does the calcium touch the lumen or is there a layer of an intima in between? Now, here's examples. This is thin cap. This is another thin cap. This is another thin cap because the calcium is abutting the lumen. Thin cap, thin cap. But this is thick cap calcification. There's a large layer of intima on top of the calcium, and modifying this calcification is very different to the other 5 in this pattern. These calcium morphologies can easily be distinguished by OCT. It's important to be able to recognize the difference between IVUS calcium fracture and OCT calcium fracture. IVUS calcium fracture leads to a reverberation of signal past discontinuations of the white line that's in the luminal surface, but OCT is clearly displayed as this box type pattern. So let's take an example of deep calcium. In these situations, or thick cap, intravascular lithotripsy, laser, non-compliant, or specialty balloons may be of the greatest utility. Let's take a look together. Here's an example of a patient who has a thick cap calcification. This is the pre-PCI OCT. This is post-orbital atherectomy. Of course, we've had no impact on this calcium because the orbital atherectomy system gutters itself into this tissue, and by the time it's actually led to this calcium, there's significant bias and pushing the calcium away and guttering inside of this vessel. In thick cap fibrocalcific plaque, atherectomy may have limited impact. On the contrary, in thick cap fibrocalcific plaque, intravascular lithotripsy may induce calcium fracture. And the reason for this, of course, is it does not require direct contact between the device and the calcium. Rather, energy is delivered through the artery wall. And this is an example of deep medial calcification on laser, which also has a similar utility compared to intravascular lithotripsy in being able to reach the calcium in thick cap fibrocalcific plaque. That is probably the most utilitarian new piece of information that I'll provide you. For superficial calcification, we have lots of choices: rotational, orbital, intravascular lithotripsy, and laser. And what you can also see is that by understanding on OCT the pattern of calcification, for example here, less than 180 degrees, you can predict how the balloon will behave. Naturally, expanding a balloon in this segment with a totally normal artery on the other side will never induce calcium fracture in this segment because the bias will always push the calcium away and take the path of least resistance, tearing the intima. If you look at the atherectomy mechanism of action, it is a wire-biased, favorable wire-biased based mechanism. Here, the catheter is pushing into the lumen towards the calcium, and what you can see is that by delivering this, we end up thinning down this calcification significantly, and that allows the following, which is to thin the calcium and finally to induce calcium fracture, which allows stent expansion. Now, it's important to understand wire-biased lesion preparation. Here, for example, you can see calcium fracture being performed. Now, here's this wire bias dependent lesion preparation that I wanted to talk to you about. You can see, you can see the tram tracking of calcification on this angiogram in front of you. But what you'll of course imagine is that if you take an imaginary track of the path of the wire will bias on the inside of this calcium nodule and very heavily gutter towards in this tortuous vessel. And this can be problematic because not understanding the wire bias can lead to this situation, which is basically cutting the atherectomy directly into the tissue and after stenting leading to contained perforation. Now, what about nodular calcification? In nodular calcification, it's really important to understand the wire bias. Again, here's an example of a patient who has rotational atherectomy. You can see that the OCT catheter is not biasing against the nodule. And after atherectomy and before atherectomy, there is literally no impact whatsoever. Inadequate vessel preparation. And now you'll be able to see why. Because the calcium nodule is on the outside of the artery, but the rotablation burr is on the inside of the artery. And as a result, we do not get any debulking. Here in this example, when we then perform rotational atherectomy, so with orbital atherectomy, you see that by placing the orbital atherectomy, we eliminate this wire bias and allow cutting into this nodule, thinning it down to the point at which we're actually able to impact it. So this imaging completely guided the lesion preparation. Thus, I would strongly suggest that we consider to use an algorithmic approach using advanced OCT imaging for advanced calcium lesion preparation. So in